So first, you will hear me repeat a number of things that has been done by the excellent presentations before. I've been listening to all the presentations and realized.
Now we cannot hear you. I think your mic was disconnected.
Oh, sorry. Now it's okay.
Yeah, it's fine.
All right, so I'll repeat what I was saying. So you will hear me repeat a number of things that has been done by the excellent presentation I've been following since the beginning, and I was very, very impressed by the quality of the presentations. And unfortunately, I will have to repeat some of the issues, but I'll try in my presentations to go on topics that were less addressed. And I hope that the repetition will make you understand how important some issues are. So. General principles. So one of the things that I have not seen addressed a lot is the fact that in conflict settings, what would be the types of research topics, which is a very, very general slide, of course. But from an NGO point of view, we think that there are three main topics to address. One is the violence itself and the displacements that eventually goes with it, often, not necessarily always, but often. The trauma, the physical trauma that I'm talking about, but it can also be the psychological trauma, and the general health. Often the general health is forgotten in the topics because research in conflict, they are all concentrated on either the violence or the trauma. But in conflict settings, health structures are often very much disrupted, and people in refugee camps have a lot of issues that are not necessarily directly related to the violence, the displacement, or the trauma, but nevertheless are a problem. And this needs also to be addressed. So the way you're going to address these different topics might be very, very different, because the objective of the research in general and what you want to achieve by it might be very different. So for example, in the general health, you might want to concentrate rather on understanding what are the main health needs. And you would not necessarily go into a clinical trial on vaccination. I heard the questions before, because if ever you want to do a research on vaccination, it's not a conflict setting that you would prefer, for the reason that were addressed by the person who asked the question. While you might want to know something more about their health, but it also has a, how shall I say that, it can also be discussed. For example, if I'll give you another example of a research doing a vaccination coverage before, I mean in general, not after a vaccination campaign, for example, is something that is also discussable, because you might know from understanding the context that the vaccination coverage is not very good because people didn't have access to regular vaccinations since a couple of years. So what will a vaccination coverage study give you? It will give you that maybe the vaccination coverage is 28% or 36% or 55%. But in any case, whether it's 24, 32 or 54, whatever, yeah, it wouldn't change at all the way you have to address the vaccination problem. The difference between 28 and 35 or even 50 is not important enough to change completely your strategy. So then these researches wouldn't have an unexpected impact. So if I take violence, for example, there has been a lot of research done, not necessarily by MSF, but also by MSF, related on understanding the level of violence. Again, I can make a similar parallel with a vaccination coverage, whereby you could say, is it really important to know whether the prevalence, if you can call it like that, of sexual violence in a camp is 25 or 54%? At the end, it needs to be addressed. Yeah. So you have to be careful that in this particular case, looking at sexual violence and how and its prevalence is something that is very delicate, very sensitive. And so you would want to ask yourself whether it's worth it. And then if I take the example of trauma, you could consider that in a number of settings, doing clinical trials in in conflict setting is really relevant. So I'll take the opposite example. Why? Because the trauma related to conflict is very different than the one related to traffic accidents. Okay, you still have broken bones, but the lesions provoked and how they are then, and the access to healthcare is so different that you might actually really want to look at improving the care at all levels regarding to trauma. So research methodology, we are defining these 5 big categories. You could go into more details about it, but I will regularly talk about these different ones because they each have their own ethical issues. So the retrospective data analysis of routinely collected data, I heard on the ethical review board talking about exemption, for example, for these kind of studies. And then the clinical trials is, of course, much more risky in terms of physical harm. So for us, what are the ethics-related specificity of conflict settings? So one is actually security. I mean, and it's not necessarily the one that you would think is the most important, but you still need to take it into account. So the security can threaten the participants of the studies, but also the research, of course. And so you still have to be careful not to increase the security issues to the participant and the researcher. So, but there is another point to security that is interesting. It is that it actually reduces access to the communities, to the participant, and to the supervision. So we have been conducting studies, for example, in Syria, while not being in Syria, because of security issues, whereby we would go to our key informant, and it brings with it its own ethical issues, because you actually delegate security problems, sort of. You don't take security issues yourself, but you're asking other people to take security risk on your behalf. And there is also very little possibility to do any kind of supervision in terms of whether, it was mentioned many often, informed recruitment was done properly, informed consent was actually taken. And so this is really, really difficult. So another point of, I mean, this sounds pretty evident, but I'm still going to announce it. So conflicting parties and violence or provoking issues with surveillance. What do I mean by surveillance? I'm not talking about disease surveillance here. I'm talking about the fact that a lot of people are watching a lot of people, much more than you would expect. And you also have a lot of rumors, and then the conflicting parties, whoever they are, will have different perspectives. They have different agendas, and they have a different way of looking at the situation. And so whenever you involve stakeholder and partners, and we'll come back to it very, very soon, they will have different intentions and views, which can be an absolute strong point, but it can also be problematic. The people in conflict setting are concentrated on the uncertainties of their situations and their lives, and the uncertainty of the reality. This is their majority of the preoccupation, and everything else for them is sort of not important. So they also are easily targeted and easily manipulated because of that, and we have to be very, very careful. Participants, it was mentioned several times, they might have issues with telling the truth, and it's not because they are not truthful and they want to deceive you, absolutely not, but because they have, first of all, their own perspective that might not be completely neutral and independent, which is also an advantage these days. But it has to do with the fact that they might be scared, or they might lack confidence, or they might want to induce something, or they might want to, please you to get something. So you have to be very careful in how to interpret how people are talking. And then the researchers themselves are potentially involved emotionally with what they see, or because of security issues or who they are. And so the neutrality and the independence that a researcher needs to have might really be be challenged. And then finally, there were a number of questions on vulnerability yesterday, so I thought I was going to put again some focus on it. We think that you have to assume, until proven otherwise, that anybody living in a conflict area is per definition vulnerable. And I think that making a distinction about a bit more or a bit less is sometimes dangerous, because you then start considering that some are actually not vulnerable. Everybody is vulnerable, and some are more vulnerable than others. But if you start saying by everybody is vulnerable, you probably did the right thing. So all sides of the conflict have civil population and have people who are put vulnerable. It's not a black and white situation with the good guys and the bad guys. The cowboy and Indian story is not working at all. And of course, children, women, disabled, and elderly tends to be more vulnerable, but we often forget that men are also often targeted on one hand, and on the other hand, they tend to be less identified as vulnerable, and therefore they get less support. So it's also not the fact that some men are potentially less vulnerable, but ignoring the vulnerability of men is also not okay. And so, of course, the vulnerability is at all levels: physical, emotional, social, economic, etc. So the power imbalance that has been quoted several times, it's absolutely there, and it sorts of ensures that there is a loss of autonomy and dignity, which is often declared by participants of this type of research. So the principle of ethics that I'm going to say, there are principles that are always there, but they're even more relevant in this situation. So I'm not going to repeat this: autonomy, beneficence, and non-beneficence, and justice, because everybody said it, but still, this is the basic. So normally I don't start with this one, but I will today. One of the challenges is community engagement. Community engagement is very important in research in general, often forgotten. You have a researcher who come, or a bunch of researchers, or an academic institution. They come and they sort of impose their studies, whichever that is, and they don't consult at all with the community. Sometimes they are going to just discuss with the community because that will give them access, but that's not really community engagement. That's nearly cheating. So community engagement is a problem generally in research. And the excuse in conflict will be used not to do it because of security issues, because of access issues, or because it might be too sensible or too sensitive. But it's only an excuse. And I think that in conflict, community engagement is even more important. It's because it's ethical, because you need to ensure not only the autonomy of the participant, but also the autonomy of the community you want to investigate, because it enables to have justice and not only targeting a number of populations and overburdening. And it can also be a force. Why? Because communities can help you in defining the research questions. They are, of course, the ones who are facing the problems, whichever they are. And so it's only fair also that they participate not only in defining the research question as a research per se, but also what are the main problems that they think that they're facing, or what are the issues that they would be interested in having resolved. It's not, otherwise we're a bit paternalistic. They can help you in the design because they can tell you in the condition, the culture, whatever, that this type of research will be more easy or more feasible or more acceptable. They can help you with the questionnaire, including issues around sensitivity and what could and could not be asked. They can absolutely help you with the informed consent form, because they can be a sort of tester to see whether or not this is something that they could understand. They can help you in the recruitment and the approach. And of course, as Jehan was explaining before, they can absolutely help you in supporting dissemination. And in the same sense, research needs to be with partnerships. And there are two types of partnerships. For me, local partnership is a must, particularly to have these global north versus global south issues. But of course, it's not only about, it is certainly that one, but not only that one. We know that in a number of contexts, you might have regional or national researchers who are very far from the reality of the population you want to research. It can be because of social economic, or it can be something about being on the other side of the conflict, or it can be because of rural urban issues. And so When I talk local partnerships, I'm not talking about national particularly, although it's also acceptable, really people who are on ground. And because of course they will be very valuable for understanding culture, security, acceptance, but also because you have a sort of obligation to support capacity building, and they often help you together with the community in how to implement, how to disseminate, but also to implement results, because dissemination of result is not sufficient. Often it leads to changes in understanding, in policy and practice, and then it can be very important to implement it. Otherwise, the research doesn't serve for nothing if nothing changes. So international and national partnership can be super important, particularly in very difficult research like clinical trials, because it will help you, of course, in accountability and in scientific value. But if you do so, you really should consider a research agreement, and it's a legal document. It's a bit annoying because it's complicated to make, but it is very important to have clearly set who is going to be responsible for the data and the data protection. There can be intellectual property issues, which is often neglected. The fact that it can be resulting in problems of access and of the results, but also of whatever has been found to the populations that were researched on, not the detail, and on the publication. So this is something that is often forgotten, and I can tell you, for having conducted or organized research with international academics, it's not always easy, because they are academics and their focus is on research, and they don't always have the benefits and the risks of the population in mind. So although I think both are super important, certainly local partnership, you still have to choose wisely who you're going to go take aboard, and because there might be a lot of different types of conflict of interest. So back to basics now. Relevance. I already touched it. People are very vulnerable. So your research has to have social values. I give you already some examples. The question has to be really an important and answered questions. And you need to think about what is going to be the expected outcome. Is this outcome going to make anybody, not necessarily me, but anybody, change something, understand something? That is very important. If the results are not going to change anything, you shouldn't come. And in the outcomes, it's not only about what you're going to, is the question going to answer an important question, and is the answer going to change something, but you also need to have a bit of modesty. Yeah, one research is seldom changing the world. Yeah, so it's a bit of both. Yeah, and the subject is also important. So is it something that is linked to mortality, morbidity, suffering, or prevalence? That's sort of important. So one of the issues with conflict is that conflict is not stable. I mean, you can have protracted crises, but there are often situations that changes. So whatever you research it might be very relevant for that particular setting and that particular moment. But 2 months later, it might not be as relevant anymore because things have changed. Yeah, or it might not be replicable whatsoever. There might not be a copy paste possible for another setting. So that means we used to say in the policy and practice changes that Jehan was talking about, that the relevance of a study depends also whether it would impact a local issue, a national issue, or a regional issue. This being said, if you only get this principle, then there are often research that is very beneficial for the local population that you will never do. So it's a balance. It's a balance about whether or not it is still relevant to do it on the local, because it will have a very big impact on this local population. The methodology, I know this is not a course on methodology, but the scientific value that is often criticized at least from an MSF point of view, because our MSF ethical board is also looking at scientific value, because we don't really have a scientific committee that looks also at the research. So they are, if your methodology is crap, sorry to say so, then so will be the results, and so will be whatever comes out of it. And so you have sort of put your population at risk for crap results. So I mean, this is something that is ethically not acceptable. Yeah? So retrospective data is something that can be used. It's true that the risk related to the vulnerable population is limited, but it's sometimes also not very strong because it's retrospective and it was not taken for the purpose of research. And data that is taken for clinical is not always very good. So you have to take that into account. The data is sometimes not comprehensive enough. So it means all the data that you would need to really answer your questions are not in there. So this is also something that is really important. I talked before on the truth. So how worth is the answer of some people you would question? Not that people want to tell not the truth, but because maybe you don't dare to ask all the questions, or you didn't take time to call the questions, or your questions were not really nicely put. I mean, this is also super important. And then who is collecting the data? If you are sending a 40-year, I mean, it's not about a 40, a mature male asking an adolescent girl about their sexual life, you know, that might not really give you very strong data, to put a bit in extreme. The study design, of course, sometimes, you know, a cross-sectional is not good enough and you have to go longitudinal, and sometimes you're looking at it and you might actually need to have a control. For a clinical trial, there is a big debate on whether non-randomized is actually worthwhile, and it is an important debate. And then, of course, your data analysis and your interpretation is also very important. So you have always to balance the feasibility of saying, I prefer to do retrospective data because this is something I can do for security reasons, for vulnerability reasons, for risk reasons, but then how good is going to be my data, and is it worth doing it because easy doesn't always mean good. Yeah. So the benefit risk assessment is something that has been talked a lot, but I still am going to go about sorry, I'm going to also talk about it and try to focus on things that are less important, I mean, more important. So everything is a balance. The balance is different in conflict situation because of vulnerability, but research is always a question of balance. So it means that you need to make an analysis on the benefit and the risks. And both are over and underestimated. And I have seen researchers struggling with making this balance. And so it's all about identification of the risks, not overestimating the benefits, sometimes trying to look at whether the benefits can actually be more important, and trying to minimize the risk. And if you cannot minimize it, at least mitigate it. So a conflict environment is always highly sensitive per definition. And whoever you have in there, state, institution, non-state actor, society, it has been disrupted, and each have their own agenda. So you just have to be aware and not forget it. So there is indeed a lot of unknown, and so you have to identify what could hamper the benefits, what can increase them, what could be the possible risk, and how to reduce and mitigate them. So studies that state, and they do exist in protocols, the benefits are not for the patients, but they're for the community, and there are no risks. For me, this is a bad protocol. This means that researcher did not do the exercise of really trying to identify the risk and then explain how they will mitigate them. So the benefits to individual participants. So a lot of the studies will not have a benefit on the participant. Still, I believe that if you have to make a choice between different researches, you should aim at this one first. And we really understand that this is not possible in many of the studies, But still, you need to think that the participant is taking risks, and therefore they should have as much as possible benefits themselves. Yeah. In clinical trials, this is often the case. It is much less the case when you go talk about issues related to understanding violence, etc., etc. This is not going to be directly beneficial for the participants. So one of the things that sometimes say is that, okay, if you find something, maybe you might not be as a participant a direct beneficiary, but your family will, because if it's on a disease, for example, it will improve the model of care, or it will improve the diagnostics, or it will improve the prevention or the treatment. And therefore, when a member of your family or your group or your community has this disease, even if you have already had it, they will be better. Yeah. There has been a lot of discussions on this one because let's start with the group first, like the close groups, and I'm not talking about the family or in the family. So in catastrophic situations, and honestly, some of the refugees and some of the people in an active war are actually in a catastrophic situation, and you might nearly compare it to people who have a catastrophic disease with a very high mortality, because people who get bombs on their heads are in situations that are life-threatening. So asking somebody who is in a life-threatening situation whether they would like to participate on a disease, on a research out of altruism is something that has been questioned a lot, and it has not so much been questioned in a conflict situation. It has been questioned related to diseases, but I think that you can actually make the parallel. So you should not assume that a participant, per definition, is altruist enough to be able to take a lot of risks, not for the benefit of himself or herself, but for the benefit of other people, because that's actually not necessarily the case. And so you should not take that as a principle. I think it's very important. Solidarity, which is a broader concept than altruism, is also not necessarily the case. So if in a non-conflict area, you could say, okay, people are close to their community and they would be solidar to the community. But as was mentioned earlier today, and I completely concur with that one, refugees are not a community, or victims of violence are not a community. Victims of sexual violence are not a community. And because they are from very different, first of all, they don't want to be called a community, and they're for very different cultures, countries, ethnic groups, religious groups, and they do not relate with the other groups. And I would say worse, we can see that in the European migrant, I mean, it's not only European, of course, but in the European migrant, which is a crisis where you have people coming from very different backgrounds, the people are not solidar with the next wave. Actually, it's rather the contrary. We have seen discrimination and sometimes even racism from the first migrant wave to the next migrant wave that is much stronger than the host population, because they have the impression that the next wave is going to be taking away the privilege that they managed to receive, or their opportunities. So it's not true that you say, okay, it's not going to benefit you, but it's going to benefit the other migrants. Well, people don't care, so it's not a real benefit. And then finally, awareness leading to change. So you say, yeah, okay, I'm going to demonstrate that there's a lot of violence, or I'm going to demonstrate this or that one, and saying, okay, this will lead to change. It's not always the case. You have to be a bit realistic about what you want to demonstrate, how people will react to whatever you show. This being said, the little bits and pieces might actually do that. It's just your research might not be enough, but if others do several researches, the combination of the different researches showing something similar might actually do it. And the same applies for strengthening the health system and the infrastructure. It's not always the case. So you do have benefits. One of the issues related to qualitative research in very vulnerable populations is that there is a story about retraumatization, yeah, which I will talk about later. But people sometimes are very happy to be able to tell their stories. And it's not true that you say, okay, it is beneficial for them sometimes to know that people are interested in their story. And sometimes it's beneficial for them to be able to tell it. And it's not only a question about a risk of traumatization. And of course, awareness creation might actually improve their living conditions because it can be, showing that you have diarrheal diseases because the camp doesn't have latrines might actually improve the hygiene situation in the camp that they are at. It's just an example. And the same applies for health issues that are demonstrated that might actually lead to people addressing them. Whatever research done on models of care, intervention, medical countermeasures, whichever, they might actually need to new policies, protocols, and improvement of care. But this is only when it is linked, as Gian explained, to a dissemination strategy and an advocacy strategy. Dissemination is sometimes not enough. One of the important points that is benefits that is often forgotten in the way you are, not your research methodology or your relevance, but also the dissemination and whatever deal you made with partners and the IP issues that we're talking about, is that whatever has been proven, it should be then the access to these proven interventions should be guaranteed to the participants. Otherwise, you are in a completely unethical issues. So for example, if you have a proven new drug or a proven new vaccine, I mean, that's the simplest example, but it goes much further than that, then you cannot have the pharmaceutical company putting an IP on it so that the country will not be able to import it, the country will not be able to have the regulatory authority accept it, or it will be way too expensive, and the people who actually contributed to the research being successful will not have access to this kind of drugs. This is absolutely unethical. And the same applies for results. So the results is a benefit. And you might think people don't care. Well, it's not true, and you should not assume that. So sending back results to the research participants is something that is very often forgotten, and it's actually completely not fair because it is a benefit for them. So risks, so emotional distress and re-traumatization, talked about it. So because people are reliving or reviving their negative experience, it can also, of course, reveal emotion that they had buried far away, of grief, loss, shame, whatever. There might be difficulties in addressing taboo and sensitive issues that, you might be a bit, it might not be so easy for them to address it. And it can cause emotional distress, that people have to talk about issues that are not necessarily that sensitive, but when the research is done outside of a confidential space, they might be traumatized by knowing that other people hear it, yeah? And these other people might include their family members. So loss of dignity is something that we also often forget. Dignity is sometimes the only thing that the people within conflict setting have left. And so if you harm their dignity, you're giving them the worst harm. And it's something that is difficult to measure, but you do have to take it into account. So it is loss of autonomy, is loss of dignity, loss of protection, because your research is not done in a protective way. It's also the sensitivity to their culture, their gender, the conditions in which they live in the context, the famous power balance we were talking about. And the power balance is a white, non-white, or the global north, global south issues, absolutely. But you can also have a power balance within a same ethnic group, within a same camp. That we know that power balance are at all levels. It can be a gender power balance. So we have to, define. We say, for example, that in the clinical practice there is a power balance per definition. So ignoring that by saying, no, but I'm from the same ethnic group, or I am a nurse, or I do, no, nonsense. There is a power balance per definition. And it's not that you should not ignore it, you should take it into account. So whenever you address people, you take into account that there is a power imbalance, and then you're doing the right thing, because you cannot just remove it. It's not possible. So there were talks previously about false expectation. This is can be because of therapeutic misconceptions, but not necessarily when you're not very clear. And sometimes you need really to be clear, or loss of dignity if you're doing research and there is no benefit whatsoever for the research participant. This is also harming dignity. So what is the mitigation for this? Because like I said before, you have to identify the risk, and then you have to either reduce them if you can, or mitigate them. So when you understand the context, and you might, it might be much more difficult than you believe, and that was mentioned in the talk yesterday a lot, which I think was very useful. It's not only about reading and looking at the video, it's really being there and talking to people and understanding. So you need quite some preparation. Protecting space sounds ridiculous, but I remember a research that they wanted to do whereby they would ask adolescent girls whether they had been victim of sexual violence in their homes, but knowing that next door the father was there, yeah, and so it is not it's not only in particular, let's say, macho, if I can call it like that, society that this will be difficult. I can tell you in my and in non-conflict and in my culture that would also be difficult. Appropriate. So the environment is important, and going home, it's not only a question about the other household members being there, but it's also because the people can see that the research going inside the house. So in surveys, this is something that needs to be taken into account, that you would not stigmatize a person by going in their homes. In their homes or in their tents or in their particular space. This needs to be prepared, really. So it's privacy and confidential. It's both. Appropriate resources. Well, you have it's clear for me, yeah. And like I said, be aware that it's not only a question about a male or a white or a Christian or whatever. It's not only about that, but it's also about a research that is sensitive enough, that is trained enough, and that is not having any kind of conflict of interest of causes for increasing the power imbalance. Like I said before, doing research and having it prepared and discussed with the communities before, including with potential participants, is something that will reduce significantly the risk of dignity loss or distress, because you will be much more aligned with what people can handle. Psychological support was mentioned several times as well. And then for taboo and sensitive issues, there are ways around it, sometimes to be able to address them. So the lack of confidentiality and privacy, in the morning, the ethical review board representative, sorry, I don't remember the name, talked about it very extensively. It can be caused by much more than you might believe, actually. So the environment space, I already said it. Sometimes it is because of your translator who doesn't pay attention in divulging stuff of the research that he's not aware of, or the culture mediator you're using, or the research themselves. If you do research on medical care, the discussion that you can have between care providers might actually divulge and have a problem of confidentiality. Sounds shocking, but I can tell you it's the case. Patient files, case report from informed consent, they're all identifiable, yeah? They have the name of the patients. If you displace them and you move them around, or you put them in a bag and then somebody steals it, or you lose it, or whatever, this is really risky. And sometimes there's not enough attention paid to it. You have research who use little notes, And these little notes can also be, you know, a paper here, a paper there, you lose it. Sometimes it's not enough taken care of. And then, like I said before, in conflict, per definition, there are mics all over the place. We used to say in conflict area as expatriates, but of course it has nothing to do with expatriates, like bonjour micro or hello the mic, because we knew that we were under surveillance. And so beware of unwarranted listeners. So we have also this issue. That's not only research related, of course, but you can sometimes talk with your fellow researchers in a car and you forget that the driver is actually listening. And it's not that he's necessarily a spy or anything of that sort, but he will hear stuff that might be from his community and he might actually recognize the participant. And then another point that is very important, that is often forgotten, is that when you interview people, they might actually talk about a third party, about somebody else, and they might disclose very sensitive information about another person that is identifiable. And of course, this other person is not aware that he's a sort of indirect participant in a research, and he certainly, or she, didn't give consent. So you have to be very careful that this person is protected, and usually you have to talk to express to the, I mean, in focus group discussion, this is something that is always put on the table, but also when you discuss with participant, you have to tell them that it is very important not to do so. Okay, so breach, unauthorized, unlawful, intended, people can actually try to steal your research. Targeted, accidental, or opportunistic access and use of data is per definition a source of very considerable harm. So this needs to be absolutely avoided. But there is another breach in data protection that is forgotten, that if you lose the data, or if you did a breach of ethics, you might not be able, I mean, if you lose the data, or the ethical review board is withdrawing its approval because you did a breach in ethics, then you will have put your research participant into risks for zero benefit, because you cannot publish the result, you cannot finish the results. And this is often neglected. So this is super important. And then I want to say something about pseudonymization, anonymization, and even aggregation. It's very relative. Why? Because people often understand pseudonymization as replacing the name by a code, or anonymization by removing the name. But there are many other ways to identify participants. And in conflict situation, or in violent situation, for example, if I talk about Gaza, for example, and a trauma center in Gaza on a Friday, and I say I have a male, 22 years old, who came with a sniper wounds on his thigh that date. You think, okay, I didn't put a name or anything, but I can tell you that some of the people will know exactly who that is, more than one. And so you have to be, anonymization is much more than the name. The problem is that if you remove, it's a combination of like I said, the age, the date, the type of lesion can identify a person. So in research, the problem is that if you remove too much of these, then your research database doesn't mean anything anymore. So researchers are obliged sometimes to have pseudonymized, because they have to link different databases with each other, or different rendezvous, for example. So if you have to look at a patient that had a consultation and then a surgery and then went to intensive care, and then you need to have to follow the patient that might have each, I mean, not a unique identifying number. Unfortunately, that happens a lot. So you might need to link participant one to the other, like, you know, the sister or the brother or family members or something like that. So pseudonymization sometimes you cannot do without, and anonymization is not always possible. So you have to be very careful, because it is really risky. Even aggregation can be problematic, because it was mentioned before also. If you say I aggregate, but I aggregate in still saying that all the women from that community have a sexual transmitted disease, it can still harm the full group. Huh? So this is super important. So how do you mitigate that? Well, you, like I said before, again, you have you have the environment of where you do the research has to be, and the research team is very important. You of course have to teach and train them, because people are very, very often disclosing confidential information without being aware. They don't do it on purpose. They just didn't think about it. Yeah? You consider data minimization, but of course, this has, like I said before, it has its limits. But nevertheless, data that you don't need for the research, don't keep it. Yeah? Anonymize, like I said, as much as possible. And sometimes, and it has a lot to do with the dissemination that we're talking about. Sometimes you might want to broaden the time. So like I was saying about the admission, you would not say, I mean, people admitted on this particular Friday, but you can say people admitted in the course of the year 2020, or you could say in the course of the first trimester. And so it's not completely anonymizing it, sort of, but it reduces the risk of identifying a particular individual. Or the location is also important. You can say, instead of, I mean, in my case of the wounded in Gaza, it wouldn't make sense to say somewhere in Israel or somewhere in the Middle East. But sometimes this is something that you could actually do. And then you can do age, for example, to say, you don't say a young man of 22, but you say a male between 20 and 40. That also reduces. And I know this is not always possible, but if you can, you should consider it. So paper-based and digital, this is an absolute max. And one of the things to do it is to very concretely go through what I call the flow. It is, you are going to ask yourself the question, okay, this data, who is going to, I mean, this pair, the informed consent for example, who is going to take the informed consent? Once it is signed, or it is a witness signed, where is the paper going to go? And then from there, where is it going to go? And then where is it going to be? And you go and flow, you know, the flow of every of these little database, and this will enable you to say, okay, this I haven't consolidated, this is a risk, this I have to take care of, this I have to secure. If you think, yeah, but I will do it, it's not good enough. And often it's a remark from the ethical review board, and they're completely right, according to me, where the way the data is going to be kept, moved, etc., is not very clear. Password encryption, they have their limits also. So you have to be very careful. Like, for example, a stupid thing is to have a password on your computer, but you have a little note somewhere, like a post-it somewhere with a password, because otherwise you forget it. Yeah, then it's not really password protected. And so you have to clarify also who is going to have access to the data, because not everybody in the research team necessarily needs to have access to all the data. And then it was mentioned before, storage and retention time is very important. Where are you going to put it? Who is going to be responsible? If people need to go back to the data later on, who is going to be, who is it? If a research participant, for example, withdraw consent, how does that happen? Yeah. And then sensitization of training of all this, like I said, people are often not aware. So you do have to train everybody that will be involved in the training about this confidentiality. Physical harm, I cannot not talk about it. Of course, it has to do with security. The fact it can be directly, if you ask a research participant to come to a particular place for the sake of the research, you know, the route to on itself might be dangerous, and they might be at risk of physical harm. Or it can be indirectly through identification, like I said before, or confidentiality or privacy breach. When you have medical interventions, of course, you have the classic ones that has nothing to do particularly with conflict, but it's still there, because sampling can cause harm. The quality of the diagnosis can be harmful, and the treatments as well. And then the consequences of research participation. In migration particularly, so, or in refugees, the fact of participating to a research might make them miss opportunities for themselves, opportunities to go to get food, opportunities to get vaccinated, opportunities to get sometimes even a legal status, because they were busy in the research. And we should not not forget them. And then the forced to displacement, this has to do with something I will talk about later. So of course you have to assess security, sounds logic, but I still mention it. The rest, I think I made a problem with my slide. So misuse of findings. Jehan talked about it. I'm looking, of course, at risk, so I'm looking only at the negative side. But yeah, state and non-state actor can, of course, suddenly localize individuals that they didn't identify. They can identify them, and then, of course, they can create harm. They can also use the research in a form of manipulation. They can say, okay, this research, we have seen that in camps whereby sometimes results pushes the state to move the refugees elsewhere, which they might be worse off than they were initially. And then in general, so that including for ourselves, it might increase stigma, it might overburden population groups because they want to be researched further, there might be stereotyping, and then there might be misinterpretation and misrepresentation. So like it was very well explained by Jehan, so I'm going to be brief, you need to take it into account in the beginning. Is there a risk for my research finding to be misinterpreted or misused? Then maybe I should refine my research question. I have, of course, to have a strong methodology and scientific value so that the interpretation of my findings are strong, and you can work with the people, the communities, and other stakeholders about mitigating the risk in case of publication. And then I cannot the research themselves might also be at risk. So you do have the main research private investigator, but the risk to the little people is often forgotten, and they are often much more at risk because they are often part of the communities, or if you choose them well, they're local researchers, and they of course will stay in this environment. So it is super important to think about the security also of the translator, which is sometimes, often forgotten and sometimes also not very well considered, which I think is not really fair. So there they have a security problem. They can be reputational because they contributed to your research, but it can also be emotion. It's not only the private investigator that can be emotionally involved. Also, translators or surveyors might be at risk of emotional distress. So there is a balance to be taken. Or is the security risk worth the research, or is the research worth the security risk? And of course, there is always mitigation possible, hopefully. And then we have to really consider and respect the little people under brackets of research staff, and be ready not only to have psychological support for the participant, but also for the staff. Informed consent. There was talked a lot about it. So I'm going to just say that this power balance needs to be taken into consideration when you take informed consent. It's super, super important because they're super vulnerable. A lot of people are in a sense of complete despair, and they might accept anything because they are not a clear thinking. Some might be actually disabled, so you can have a trauma patient who is in coma, so they are not capable of giving consent, of course, and then you have the minor issue. So it's important to do consent by ensuring that it has a true value. You have to be sure that it is actually a consent that people have been giving, that there is no sense of coercion, that people don't think that if they are not going to accept the harm, they will actually either not get the benefit that they are entitled to, or worse, they are put at risk. Therapeutic misconception is super important. It's not only important for the informed consent, it's also important later on. So you have to disconnect the research from the care at some point. You have to clearly state that to the patient, which is not always done. And then they should not accept research in the hope of getting later on support. And that was mentioned several times about somebody going into a community identified as somebody with potential power, a decision maker, or an NGO, or a state actor. And then they hope that by participating, they will get food, or they will get access to legal support or whatever. This is super important. What was not talked about, or I didn't hear, is the story about legal guardians and representatives. It's always a problem. It's always a problem to identify who are actually the legal guardians and representatives. It's a problem because even if legally this is the guardian and the representative, this person will not necessarily have the best interest of the participant in mind. I mean, there are power balances in conflicts that are increased. Yeah? And then if we have seen that in some of the conflict area, the conflict is also within a household. We have internal conflict whereby two parties are in the same family household. So this is super complicated. What we have seen also that in some of the research that is urgent, for example, in a clinical trial, when you want to do a clinical intervention and you cannot wait for days and days for the legal guardian to appear, what do you do then? Are you just not considering a legal guardian, or are you considering, and who are you going to choose? So these are discussions that you have to have. It depends on the research and on the importance of benefiting the intervention, of course, but it's still very important. These discussions, they are not done often. So they're put in the protocol, like if it is a minor or if it is disabled or whatever, we will have the legal guardian, but nobody talks about who is the legal guardian. Is it okay to have the legal guard? And if you don't find it, what happens? So this needs to be thought in advance and discussed with the population often, or with key stakeholders. Sometimes also a discussion you can have with the ethical reviewer. They usually are very open to discuss these kind of issues if you don't know how to do it. And then often forgotten is that somebody who is not capable of giving consent because of legal issues, because it's a minor or because it was mentioned in a previous talk, in some cultures, it is not the woman who will be allowed to give consent for herself. It is a male member of the household, and that can differ depending on the context. But that doesn't mean that suddenly this woman doesn't have any autonomy and she's reduced to an object. Absolutely not. So even if you have to have the consent of a legal representative, you still need to ask assent from the woman. Or sometimes you would do both. So assent doesn't have a legal value, but it's still something to do, which means you usually explain more or less the same. I mean, if it is an adult, you will have the same information in the consent as in the assent. And so if the husband says yes, but she says no, you don't do it. Because at the end, you're not going to go against this woman. Yeah. For minors, it is the same. I think if an adult, the father or the mother accepts, but the child does not accept, you should not do it. So the assent for minors, it will depend on the country. It will depend. For some countries, they will consider a 12-year-old already, and other countries will say 15. So you have a bit to see in the country where you are, from which moment you would have assent. Assent is a paper also, and you want them to sign eventually or to give an oral consent. Even if the child doesn't have the age of an assent, that does not mean you should not explain to the child what is going on. And of course, for minors and even mentally disabled, because you have gradation in mentally disabled, as you know, it is super important to explain to them in their own words, so not the same as for the adults, and ensure they understand. A minor still has an autonomy, yeah, a form of an autonomy. And then proxy consent by culture. So this is my term for the woman. And then I want to say something else, and I will talk about myself because I think it's the fairest. We have seen that sometimes where there is no legal representative possible because they're not there, a minor that is a refugee might not have his parents, that you would have sometimes consent given by the community. So there we go again with the community. Well, if for some research participation, and let's say that I have a deadly disease and they want to give me an experimental treatment, I know it's a bit extreme, but sometimes it's easier to give extreme examples. I am not sure that I would agree that the mayor of the city where I live, that I don't know who he is, I mean, I know his name and I know his face, but I don't know him personally, would give consent on my behalf. So it's not always okay to say that the community is actually the garant for an individual. So this really needs to be discussed with potential participants, whether they would agree, because in some culture it would be okay. Okay, so it needs to include all the information that was very set by the previous talker. So I still want to talk about later on about the storage and of secondary use of data and samples, but that's for later. And so super important: the right to refuse, the right to change their minds, the right to consult their data, and the right to object at some point. So no jargon, culturally adapted, age adapted for the assent. You have to do sometimes retro-translation to be sure that the translation then is okay. And the same applies for translators. You might want to use both to be sure that their little details might make a bit different. And like I previously proposed, when you can test it to potential participant, I would certainly do it. So that's for the form, and the informed consent procedure itself needs to be distinct from the care, as is the recruitment. So we had a lot of problems in MSF. We became extremely strict by saying you cannot recruit patients at the consultation waiting area, because it is clearly nearly impossible for them not to have therapeutic misconception or to feel coerced. This is one. Secondly, in a consultation waiting area, you do not have any kind of confidentiality, because you have many people that can, of course, hear what you're talking about. And so particularly for consultation on very sensitive subject or on mental health, for example, you will immediately induce in the patient/participant the reflex of not disclosing what needs to be disclosed to the caregiver, because of course they will say, whoa, 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 whoa. I have already to, you know, their confidence into your capacity as a clinician to keep confidentiality, pardon, is going to be reduced. So reduce substantially the trust of the patient into the care system and the quality of the care given. So it is space and timing. So we also said you can recruit patients after consultations. We don't have a problem, but you do it after the consultation, when the consultation is finished and the person knows that whatever he or she needed to do in consultation is finished, and preferably also in another space if it's possible. If you don't have the doctor recruiting or not the health promoter recruiting, or then of course it will also diminish the risk of therapeutic misconceptions. And then the intervention, that's not always possible, but if you can deconnect the research by saying, okay, what I'm going to do, this is research, this is your normal care, and this is research, and you clarify that very much, that also helps, but it's not always the case. So it was explained also before, I'm not going to go into detail, between the signed and the oral consents, and sometimes there is a need for a witness. And this is when you really want to be sure to demonstrate that you did a good job in your informed consent procedure. So some specifics, I'm nearly done. Some specific in qualitative research, I'm not going to repeat. You need to understand your culture. The environment needs to be protected. So like I said, going to the home is not always a very good idea. And then there is a lot of importance put into observation, and it should be. Yeah, a lot of people might, because of their status, because of the type of research or the conditions where they're in, not be able to talk freely or to feel the possibility. But you might be able to identify a lot by the tone they're using, their behavior, or they're really anxious, or body language can be very important, but it's also difficult to interpret. Huh? So it is very important to do that with somebody from the culture, because the way we are using our body language is very different from gender, from age groups, but also from culture, of course. The use of quote for témoignage and in the narrative. People don't necessarily expect, even if they have given consent, that you will literally use their phrases into the publication. So you need to be very clear about this. You need to be saying, okay, I'm not going to use your words, or I'm not going to use your words. And this is even more important if they're talking about others who, like I said before, didn't give consent. And it can be much more identifiable than you think. Huh? So you need also, one of the things that we do if we use témoignage, even if they have given consent, because like Jehan said, people don't always really realize what it means, is to say, okay, this is the quote we're going to use. We're not going to use your name, but people might, through the quote, still identify you. And this is where we're going to put it. And then you have to be honest by saying that if you publish it in a scientific journal, if it's on the net, if it's on the internet, if it's digital, it's not possible to retrieve it. I mean, you might say to the people, but it's an absolute lie, because we know once in the internet space, even if you retrieve it from the website, from the whatever, from the journal, it's still in there. And a lot of people can still have access. So this needs to be very, very clear that once published digitally, it is virtually impossible to erase it. Yeah? So we ask people to validate and the quote themselves and whether they're still okay with it. Focus group discussion, I already said, very important to talk to the people, because people will disclose without, unwillingly. They will not pay attention that whatever they have said here might actually put another person in danger. And then the emotional in focus group discussion, it's even more important to ensure, in qualitative research, the emotional involvement is, of course, much stronger. Then retrospective data analysis. Like I said before, be sure that the quality of your data is there, and it's not only the quality of the data, but also the completeness of the data. So if you have bits and pieces of data here and there's also only so much you can do. It might be a very good idea to start. It might be a very good idea to say, I will first do a retrospective data analysis, because the risks are quite minimal. They're not zero, but they are much less than to go into addressing questions to patients often, because it's easier to anonymize there. And then you can refine your question. But it might also be that there are better solutions, because there will be a more scientific value, and so they will give you better results. The informed consent is, I want also there to clear. People say it's a retrospective data analysis, so informed consent was not possible. Well, I disagree. It is often not possible. It's not always not possible. If we are doing in a conflict area, we are having a cohort of tuberculosis patients or HIV patients or another type of cohort, and just imagine a simple one. A cohort means that in the clinical sphere, you will see this patient regularly, which means that you have access to this person. Maybe access because you come for the next rendezvous, or access because you have access to this person because you go do follow-up of compliance of drugs or whatever, or health promotion at their home. In that case, there is a possibility to ask consent. I'm not saying it's easy, but you at least could ask yourself the question whether it would be a good idea to go back to consent for consent. Yeah. Then if you can't, and you have to explain it, I think I always want the research to explain, even in retrospective data analysis, why they can't obtain consent. Then there is a question of waive. Yeah. So I don't like it when they say the ethical board have exempted from. So no, this is okay. When they sometimes say informed consent is not needed. And I think this is not correct. Informed consent is always needed, but it's not because you need it that you manage. It's a very different story. So we have to tell our people, the researchers, informed consent is always needed, but in some occasions it is not possible. And when we think that it is justifiable not to, it's not justified not to do the research, we ask the ethical board whether they would waive us. They would waive it from the need of informed consent. Yeah. there was a talk about exemptions of ethical full review when it is a retrospective data analysis. So we have in the MSF ethical board that was explained earlier this morning, it exists, but it doesn't exist blindly. There are still conditions. And one of the main conditions is that the risk to participants is minimal. In other words, the whole story that I said before about really looking at risk still needs to be there, because it's not because it's retrospective and eventually anonymized or aggregated that there is zero risk. That again doesn't mean you won't do the research, but it means that you have understood the risk and you have done the mitigations. One of the things that we do, and in conflict situation, it is more often than not, the majority of the studies of retrospective data analysis still go through review, because we consider that the context is one of high vulnerability and therefore it still needs review. Another point, and it was a question also, MSF Ethical Review Board never is done alone. Because it's true, the members are from Canada and Australia and where else, and so they don't necessarily understand really the context in Gaza or Iraq or Syria or whatever. Of course, they read the newspaper, but like we said before, this is certainly not enough to understand little local details that might put people at risk, and that should be considered in terms of mitigation. So we have always a national one also. We are not comfortable when you have the two ethical boards that accept exemption. So we're okay if the National Ethical Board is not there, or there is a consumption, sometimes it is, but there is not there, then for a retrospective data analysis, we will still go for a full review. Or when MSF is saying, MSF ERB, Ethical Review Board, is okay for an exemption, then we will still make sure that the National Ethics Committee has done a full review. Yeah, so we really want to balance this. So I already said it. So it's not because it's retrospective and that there is an absence of intervention and anonymization that you have zero risk. And when you do the risk-benefit balance, it's not only about risk, it's also about benefits. So you do need to look at what is it going to benefit the participants or their community. If there is zero benefit, then I think because there is never zero risk, it's problematic. And so you also have to, one of the things we have seen, and I know that in conflict situation, this is quite difficult, but it's not impossible. If this is, I'm talking for NGOs, so people who are involved with NGOs. If you have a population group that you address for clinical care, and you know already in advance that the chances are enormous that you will do a retrospective data analysis, then you have actually two options to be ethically correct. Either you say, okay, let's do a prospective since the beginning because it's fairer, it's going to be better quality, you are much fairer with the patients. Which is not always evident, but I think that sometimes we should say no, don't do this retrospective. You can still do it prospectively. It will be much better. Or you can be clearer with your patients. You can say, okay, we are enrolling you. Let's talk about this TB project that I was talking about before. You have this course. You know that you're going to do all sorts of retrospective research on that. Then you tell the people, okay, it's part of the general data protection regulation in Europe. So it's to say, this is the data that we're going to take for your patient care and for monitoring the program, but we might actually also anonymize them, so you shouldn't be recognizable for a retrospective study. And then you can do that with an opt-out, or you can do that with a consent. Transparency is already better than nothing, but it's not very strong. Why you explain it to people? You can even ask a consent on a retrospective data. So secondary use of data, it's my last slide, then you're off. So what it is secondary use of data and samples? Here I'm talking about research. Yeah, a retrospective data analysis is actually a secondary use of data, but in this particular slide, what I'm talking about is research that was done with a database, with a data collection and eventually samples that are, needs to be stored for a while. And then you have other researchers, could be the same researchers or other researchers that want to use it for an additional study, whether or not combined with research from other. So it has pluses. It has pluses because merging different researchers might actually be a very good idea to be able to get stronger results. Yeah, so it might be really super important. It might also be that other researchers have better means than you have, funds or whatever, to do additional research that you were not capable. I mean, capable is not necessarily always the word, or you didn't have time, or you didn't have the expertise, or you didn't have whatever. That might be super important. It avoids, of course, the fact that you go back always to the same populations with a new research question, if actually the answer might be found in the data collection and the databases that has been already taken by a previous research. And it might also improve the fact that in very unique contexts and conditions where research were taken, you're not losing the possibility of doing whatever needed because it might be gone. And so one of the things that were talked about often was, and I know it's not conflict, but it's still a very vulnerable situation, is in Ebola, for example, whereby before 2014, of course, the Ebola epidemics were so short that there was often no time to do research. So if ever research was done, then it had a very, very big value. You do have negative points, yeah? And what the most important is that the patient did not give consent more often than not for secondary use of samples. And if you look at research I did, and I still continue to monitor research done on this particular topic of what does research participant or potential research participant think about secondary use of data and samples. There is very little, so I think it's a really important research subject. Of course, it's not so much into the MSF, but I push a lot of researchers to think about it. And when the research that you can find, they have, of course, different methodologies, they're in different places, but you would be surprised about how people react. So I can tell you that the people, I mean, you can say, of course, but nevertheless, the people in Japan or the people in Congo or the people in the Middle East, they handle very differently. They handle differently. And then one of the things is who can do the secondary research. It's not a detail. So you have a lot of communities, let's say, who would say, I would be agreeing that secondary research is done, provided it's not Americans, I swear. Or you have, I agree for secondary use, provided it's still in the same topic. For example, you did a research on HIV, then they say it's okay if it's HIV, but don't do it on measles or don't do it on something else. So because it's anonymized, or because and it's even more sensitive for samples. Ooh la la, very, very sensitive, even if it's anonymized. Why do I think it's important? Because I don't always agree personally, including with ethical boards. If a person's sample of a person data, it's still something that came from them, that they gave you, and you are not to do whatever you want with it. It's not okay. It's not okay because they contribute to your success, but they're not necessarily having the benefits, and they taken risks and they don't have a compensation for it. So it's super important to understand that in the majority of cases, they have not given consent. And they are not necessarily agreeing that ethical board can speak on their behalf by saying it's okay. So I think it's important to note. The relevance of the collected data. For me, the most important example is qualitative data. If you ask particular questions on patients on a particular topic, because you explained your research, you have to do that in the consent. You explain why you want to ask the question, what is the objectives, what are the expected results, and what is the methodology. So people will, of course, answer according to the questions, but still in the mind, the research objectives. So you cannot use this for something that has a complete different question, because it's not valid anymore, because people would not have answered the same had they know that, you know, the question could be asked differently. And then yeah, I mean, it's not always the case. If you merge on the same topic or the same population, different researchers, the methodology might actually be that incompatible that it doesn't work. Yeah, but there are mitigations. So one of the things that we ask more and more is, whenever we think that the research that we did and the data that we collected or the samples have actually value or will have value, or it's in unique conditions, blah, 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 we actually include a separate consent box into the consent. So we explain the whole story, the whole research, like we said before, and then we add, there is a possibility that when we store the data or the samples, which you have explained where you're going to do that, that people would want to use it for an additional research under these conditions, because it's going to be with a protocol, it's going to be on the same subject, and it's going to be after ethical approval. Would you agree? You can agree separately, yeah, or not separately. Both are option, depends on the research. If you think it's really unique, it's really important to give the possibility of a second, you can decide, you have to the participant, you can decide on the full package, it's a yes or no, or you can say, I agree for the research, but I agree for the data, but I don't agree for the samples. You can do that, and all the combinations. Whenever you do secondary use of data, you have to, that's why we want ethical review, because you have to revisit the benefit risk, because the new research question might actually shift the risk benefit balance. You do have to really take care that it is really anonymized. Like I said before, don't take away the name and you say it's okay. If you have research partners, which like I said, I really think you should have, you have to ask, because it's only fair, the approval of all the research partners. And what I didn't say here is, but if it's a possibility, of course, you should also do that, is if you have the possibility to go back to the research participants, so provided you didn't include the separate consent, then of course, this is the first thing to do. And I think I talked way too long, so I'm going to stop here.
Thank you so much, Dr. Anik, for the talk. I think it was very detailed and beneficial. And there is a couple of questions that we can address rather quickly. So the first one, can you elaborate on data validation, selection / collection / analysis? Basically, how the validation is done and who validates the data?
It depends on whether it's prospective or retrospective, of course. Huh? So for retrospective, the data validation at the collection site is minimal, because it has already been taken. And so it is very difficult to go back and ensure that the clinician had actually written whatever needs to be written. I mean, this is very difficult. However, there can still be a procedure of what we call curation, which means that when it's possible, and again, you have to look a bit at the risks of doing that and where you do that and who is doing that, is to go back to the patient file. Because often when we do retrospective data analysis, we use the database that we have for service monitoring, service of program monitoring. But to be, when you have, incoherencies or like a male and pregnant, that's like a classic, then you can eventually go back. I mean, a classic example for this kind of curation, because it doesn't happen so much. When it comes to the collection at prospective, then you often have the one who takes the data, and we include supervision, and that's what I mentioned before. In conflict area, it's annoying when security doesn't permit to have too much presence of people. It doesn't have to be expatriates, of course, absolutely not. So two people looking at how data is collected is one of the validation process. When it comes to analysis, we rarely have one researchers. Huh? We have several researchers who are we are working with a research reference or research coaches, and they will go to the how the analysis was done and whether it is solid and that. And it's also the advantage, which is not negligible, of the peer-reviewed journal, because it gives you a guarantee that it is peer-reviewed. That's how it's called. So it supports also, and more journals, and I think it is something that is should be acceptable, actually ask the database to be able to see whether the analysis was also correctly done.
Great, thank you so much. There's another question that we can address in the discussion. Amal has two parts because it's for everyone. Amal has two parts. One is for everyone that we can discuss in the discussion. The second one is, however, specific to MSF. Secondary use of data. This brings the issue of data transfer through how MSF handles that. Would a solution of broad consent be used?
MSF has tried years ago, it's 10 years ago, to make something that they called a data sharing policy. In fact, the idea behind was that MSF is working in exceptional circumstances, and we have it's not always optimal, the data, but it can also be very good data in terms of quality. You have a bit of everything there. And that it is sort of for public health reasons and for the benefit of a lot of communities that we're working with, the fact of using the data for research would be important, but MSF does not always have the capacity to do that. So you could sort of give it freely, sort of freely is a strange word, but put it available to researchers, provided a whole bunch of conditions. Huh? But today, this sharing policy is still not in place. So one of the first one that we took a lot of time, too much time to elaborate more on the data protection policy. So now this is there. So that is not anymore a problem, but because it is more complicated than that. So for now, what we are trying to do is to look at how can we share data from research. The reason being that the quality is often much better, and it is important, the quality, because if the quality is bad, you will get bad results. There is this not very polite expression saying shit in, shit out, and in research this certainly applies. So and the second reason is that there was consent, and therefore we are trying more and more to have by default this secondary use consent in our research. It's still not 100%, but we're trying that. So secondary use of data, there is a big difference, according to me, between secondary use of data that from research or from clinical data. So a broad consent, we try not really to have a broad consent. We try to still put in the consent, like I said, for secondary, would you agree that a number of research is done related to the topic? And sometimes we would give a very specific one, and it is related, for example, with genetic studies. We would have an even more, would you agree, for genetic studies? So a broad one, we try to avoid. We still, a bit reduce the scope in terms of years, time, in terms of who does it. For example, we could say by researchers from this country. And in terms of topics, we are not very comfortable with broad, but it's not never done, because for some topics we think it's not really very sensitive. But so the secondary use, the problem is that you actually need a team doing this. You need a team because you still need to look at whether the requester is somebody that you would agree upon, whether there is a protocol that seems to be more or less okay, whether there is ethical review done, because for us, it's still a protocol, and so it might be exempted, but it still needs to go through what we call ethical clearance, which is problematic for a lot of researchers because they're based in the US and they need to obtain the Lebanese or the Iraqis or the Afghan ethical committee, and of course from the US, it's not super simple. So if we're still in the country, we might facilitate that. And there still needs to be from the project, because they're the best placed, an idea whether it's worth it in terms of benefit risk. So it is resource intensive, but it should be done, I think, because what I said before, it has plus and negative points, but we are now more and more favorable of putting demitigation there to be able to enhance this. So it's not, well, I think I answered the question, I hope.
Yes, yes, thank you so much.